Each year, approximately 400,000 infants are born in Canada, and it's every parent's hope that their children will be born healthy. But unfortunately, this is not always the case, as 7.8% of the population born are hospitalized, mainly because they are born premature. In the process of hospitalization, 1 in 10 infants will acquire fatal infections in the hospital. However, the most saddening part of the majority of the infections can be easily prevented with proper hand hygiene compliance from healthcare workers. A study conducted by Takahashi shows that 50% of the Canadian healthcare providers do not wash or sanitize their hands before and after coming in contact with patients. This is a pressing issue that Dorcas Papula, a fellow UIT student, has done her final year of research on. Will be working us through her research study today. Hello, Dorcas. How are you doing today?
I'm good, how are you?
I'm good. Thank you for asking. I'll hand this over to you now.
In addition to what you have said, I decided to look into the effects of hospital acquired infections on the health outcomes of infants born in less than 33 weeks of gestation. My thesis statement states that is there a correlational relationship between decreased hand hygiene in neonatal intensive care units and the rise in hospital acquired infections among premature babies, infants born before 33 weeks gestational age? Here is an outline of my presentation. It shows the sequence of 6 important parts of my research that I will be sharing with you very shortly. The title of my study is Assessing the Correlational Relationship between Low and Hygiene Compliance and Increased Rates of Hospital-Acquired Infections in NICU Preterm Infants. According to Garba and Co., hospital-acquired infections are also referred to as nosocomial infections, and they can be defined as infections that occur in patients during healthcare treatments in hospitals or other healthcare facilities. Encounter with HAIs started with Dr. Semmelweis in 1847, who noted that the incidence rates of puerperal fever was prevalent in maternity ward, where healthcare givers provided care to women in labor. In his observation, Dr. Semmelweis observed that medical students and physicians were contaminating their hands with germs from cadavers and later examining women without following proper hand hygiene protocols, which resulted in increased mortality and morbidity rates in the susceptible population. Unfortunately, this same problem continues to persist approximately 170 years after. As a matter of fact, numerous investigations conducted have shown that adherence to hand hygiene recommendations remain low and improvement efforts frequently lack sustainability. To further support this claim, using the same example that the presenter has used, research conducted by Takahashi has found that 50% of the Canadian healthcare providers working in the NICUs do not wash or sanitize their hands before and after coming in contact with their patients, which results in fatal infectious diseases in 1 in 10 premature babies. In this section of the research presentation, I will be critiquing a similar research to mine. It was conducted by Signara, Lushi, and Lee. In this research study, retrospective observational cohort study was performed on infants born less than 33 weeks gestational age and admitted to 24 NICU sites. Outcomes were then measured with multivariable logistic regression to avoid the effects of confounding variables. Some strengths include the use of small sample sizes to avoid mathematical errors, which also strengthen their research. It is also essential to point that calculations were only done after adjustments had been made for potential confounders and other important risk factors, which further strengthens the outcomes of their study. Since a retrospective study was conducted, recall biases are prone to occur. However, Sankara, Lucia, and Lee ensured that this was avoided by ensuring that their data was extracted from a reliable source. In addition, they indicated in their study that there is a need for knowledge translation when it comes to the case of NI gene compliance in NICUs. This is essentially because not all healthcare workers working in the NICU follow appropriate NI gene guidelines. Henceforth, the aims and objectives of my study includes determining the correlational relationship between increased incidence of hospital-acquired infection and low compliance to NI gene in the NICU. In addition, this will be significant because the outcome of this study will result in the need for better implementation of infection control guidelines to help completely eradicate all forms of mortality resulting from low compliance to NI gene. Patient safety will also be enhanced. In this section, I will talk about my research approach and proposed methods of data collection and analysis. Starting with my methods, a retrospective cohort study will be conducted to assess the correlational relationship between low NI gene compliance and increased hospital-acquired infections in infants. It is important to use a retrospective cohort study because I am studying the relationship between an exposure that may be related to an outcome, or in this case, a disease. For data collection, I will collaborate with the Canadian Neonatal Network, CNN. Data will be collected for 20 NICU sites currently participating in the Canadian Neonatal Network from the year 2012 to year 2016. Then, the quantitative data collected will be analyzed as a bivariate to support my hypothesis that low NI gene compliance among healthcare providers in the NIC results in increased incidence and prevalence in hospital-acquired infections in infants. Furthermore, infants exposed to healthcare professionals with low NI gene compliance will be compared with infants that are not exposed to the infections using a relative risk calculation. Some potential internal validity threats that could result from doing a retrospective study includes mortality threats and recall biases. Mortality threats may occur because increased mortality rates result in high rates of attrition. For those who do not know, attrition means that the strength of my study will be reduced. Another internal validity threat are the recall biases, which are common in retrospective studies. However, to avoid this, I have decided to extract data from a reliable source like the Canadian Neonatal Network. For this study, my inclusion criteria includes preterm babies with gestational age of less than 33 weeks, those admitted into the hospital for greater than 24 hours, and all healthcare providers working at the NICU sites, while my exclusion criteria includes mothers who were shown to have had infections on admission with adequate provision of epidemiological reasons to suspect that the mother was colonized, even if the newborn is less than 48 hours of age. Also, newborn admitted and on calendar for less than 3 days. However, for my subjects will be healthcare professionals from 20 NICU sites and preterm babies that are less than 33 weeks gestational age. Since this is a retrospective cohort study, data will be extracted from 20 NICU sites participating in the Canadian Neonatal Network during the period of 2012 to 2016. To ensure that accurate data is extracted, I will extract health records after discharge. This way, I can see the progression of diseases of the individual from the beginning of treatment till the end. A visit and an email will be paid and sent respectively to the Canadian Neonatal Network so that access can be granted for the extraction of data. And lastly, consent from patients' parents will be collected before conducting the research. The predictor for my research is the rate of low NI gene compliance among healthcare providers in NICU. My hypothesized exposure is that low NI gene compliance in healthcare providers. Data will be collected and extracted. These data will be collected and extracted from the Canadian Neonatal Network database. And exposed and unexposed groups will be classified based on the infant's health records. For my hypothesized outcome is that exposure results in an outcome of increased incidence of hospital-acquired infections in prenatal infants. After data has been extracted from the CNN, I will use a relative risk measure to indicate the ratio of outcome in exposed groups. For my study, I hypothesized that low NI gene compliance among healthcare providers in the neonatal network care units results in increased incidence and prevalence of hospital-acquired infections. However, to test my hypothesis, I will consider the following variables. I will consider the number of infants with hospital-acquired infections, the number of healthcare providers working in the NICU. As mentioned earlier, this is a quantitative study and every data that is extracted from the CNN database is discrete. However, since this is a retrospective cohort study, it is important to use the relative risk to determine the risk of diseases in an exposed person and risk of the disease in a non-exposed person. Some potential ethical issues that I can face in the process of conducting my research is ensuring that every preterm patient's parents are contacted and told of the purpose of the study through email. In addition, it is important to ensure that the consents are given before carrying on to conduct the study. However, further concerns with the research ethic board from the CNN and NICU sites will be addressed as required. In the process of completing my research, this is a limitation that I found, and it is the fact that the exposure and outcome variables are collected before the study and they've been before the study has been initiated. Thus, my measurements may not be as accurate and the data may not meet my full requirement. These are my references for my research study, and I've come to the end of my study.
Thank you, Dorcas, for sharing your research with us.